Now we'll demonstrate video laryngoscopy to intubate a patient. So I'm hand ventilating my patient and we're waiting on our medications to work. And the time has come where the patient is now relaxed after the proper sedative and paralytic. Okay. I'm going to put my bag down, remove my OPA. This happens to be a McGrath video laryngoscope. This is what we use at our agency. There are many video laryngoscopes on the market, so it's important that you learn to use the one that your agency uses and you're comfortable using it. The techniques are very similar for a Macintosh laryngoscope, for a traditional direct laryngoscopy. So again, first thing I'm going to do, I have my scope on, I have suction ready if I need it. I'll look to see if I see any secretions. I will take care of that immediately if I do. If not, then I take my free hand. Again, the first critical step is getting back on those molars. You want to scissor that mouth open. A lot of paramedics forget to scissor the mouth, right? And that sets you up for first pass success because now I've got good tongue control with my blade. So I'm going to enter again on the right side of the tongue. You can go straight in 45 or 90 degree. I tend to go in at about a 45 degree when I intubate. I'm going to go to the right side of the tongue. I'm looking in the mouth at the tongue. I'm watching the blade go around the base of the tongue. I'm not looking at the camera right now. I'm looking at the mouth. Once I come midline, my blade is in. I take my free hand. I don't need to be in the mouth anymore. Now I'm going to start using my camera to visualize the vocal cords, okay? I've got vocal cords in view now. I've got my arms straightened out. Good technique. If I need to, I can always bend my knees, but again, that's more for a direct approach. The nice thing about the video is I can just look up and see the camera and people around me can see what I'm visualizing. My assistant's now going to hand me the bougie. Again, curved, gentle curve with a Q-date tip. I'm going to hook it in the corner of the mouth. I'm not looking up here. I'm looking in the mouth. I'm going to hook it in the corner of the mouth. Watch it as I twist it up to go down the channel of the blade. Once it gets around the blade, I'm going to look at my camera and see the Q-date tip coming into view. If it gets hung up, I'll twist right or twist left. If it's still hung up, I can even come back and twist the bougie all the way around upside down if I need to get it to pop through the cords, then bend it back up again. And that's a nice technique if the bougie gets hung up. Now, the next thing is I want to get the bougie to go down deep enough to where it doesn't pop out of the cords. I've got it nice and deep now. You may or may not feel rings as you go down. If the Q-date tip hits cartilaginous rings on the way down, you'll feel rings. If it's bent and misses the rings, you won't necessarily feel the rings. My assistant's now going to load my endotracheal tube as I hold down by the mouth on the bougie, okay? Once the tube gets near my fingers by the mouth, he lets go. Now I have the tube down here where I'm nice and controlled by the mouth. I'm watching here now. I'm watching where the teeth is, right? Because the teeth break a lot of cuffs in the field. As I pass the cuff past the teeth gently, now I will look up at my camera and inch the tube down a little at a time. It's a deliberate, controlled intubation. If the tube gets hung up at the cords, I'll do the same thing. I will just twist left, gently twist right until it pops through. Once the cuff pops through the cords, I'm going to go ahead and cheat a little deeper with the tube, like we discussed in the direct laryngoscopy, because I want to be able to have my tube at a depth where if I have to pull it back, that's fine, but pushing it in deeper once the stylet is removed is very challenging. I'm going to hold my tube now. I'm going to come out gently with my blade, turn my camera off, and take my own bougie out, which is the safest thing to do while I hold control of the tube. Because again, that bougie can get hung up in the tube as you pull it out, and you can pull the tube with it if you're not careful. The last step is measure my depth. Again, I want to pull back on the tube to where I want it, not have to push it deeper. So again, about 23 at the lip for a male is appropriate. My assistant will now hand me the bag and blow my cuff up. So we'll put air in the cuff to where the pilot balloon is just bouncy. And now we will go ahead and verify. Bilateral breath sounds. In a colder environment, you'll get fogging in the tube. And we will verify with continuous waveform capnography, at least 10 good breaths of capnography. And then I'm going to take a blood pressure and secure the tube.